ventricle. Motion mode recording pyramid measurement of the cardiac dimensional and motion pattern. Also facilitated analyzing time relationship with the other physical variables such as ECG and heart sound. Mode of the echo, we have A mode, basic mode, signal scan line passed through the heart. B mode, repetitive scan lines. M mode, movement of the heart can be optimized as a time motion, or M mode recording provide dynamic cardiac image. 2 mode acquired multiple B mode scan lines are legal in the appropriated anatomical location to forward shape scanner. Image that provide additional subtle information either in supra-inferior or middle lateral direction. Okay, we can see this, the Doppler echo method for detection direction velocity moving blood within the heart. We have the pulse wave, continue wave, then the color wave, and we can see this, the red and the blue. The red, we can see the flow toward in the heart, and the blue flow away from the heart. This picture, we can see how to the blood flow from aortic valve to left ventricle. Okay, now we're talking about types of echocardiograph. We have one transthoracic echocardiogram, and then it's had mainly views like left parasternal, apical, subcostal, suprasternal. A second transesophageal echogram, and intracardiac. Okay, what is the transthoracic echocardiogram? The most common in the echo technique, it is the transthoracic. A sinographic placed handheld wand in the outside of the chest to send sound waves to the heart. This sound wave bounce off the different part of heart. Transducer is placed along in the left or right sternal border at a cardiac apex at a suprasternal notch to allow visualization of aortic valve, left ventricle, outflow tract, then descending aorta, or over subxiphoid region. The transthoracic echo provided 2 or 3 dimensional tomographic image of most major cardiac structure. Then the transthoracic is the relative inexpensive, non-invasive imaging technique for diagnosis right and left ventricle functional and wall motion, chamber size and anatomy, valvular structure function, aortic root structure, and the intracardiac pressure. This picture we can see when putting Pro in the right shoulder, we can see the right ventricle, the septum, left ventricle, mitral valve, aortic valve, left atrium. When the put it probe to the left shoulder, can we see this view? Tricuspid valve, aortic valve, and the left atrium, and the aortic descending. And this picture also, we can see for chamber. In the C, picture C and D show normally contractility of the heart. Okay, this is the echo view. Number 1 is parasternal, apical here, subcostal and suprasternal notch. Okay. Parasternal notch, it is the transducer position on left sternal in the second and the fourth intercostal space, markedly dot direction in the point toward right shoulder. It is the side stage of subcontinuous subsequent echo view, and main structure can be seen. Okay, this is the parasternal long axis. We can see right ventricle, left ventricle, left atrium, aortic descending aortic valve, and this here in the echo. Also, we can see left ventricle wall thickening and can be also be assessed the thickness of the left ventricle. And this picture we can see when diastolic and systolic. Diastolic with the aortic descending aortic valve, how to be. Okay, then parasternal short axis view, the transposition, we put it in the left sternal edge in the second and fourth intercostal space, markedly dot bound toward left shoulder, 90-degree clockwise, but titling transducer on axis between the left hip and right shoulder. Short axis view are open tied at different level from the aorta and the left ventricle apex. Okay, and parasternal axis view, we can see papillary and assessment of the papillary muscles. We can see the mitral valve level, aortic valve level. Okay, this view, we can see the mitral valve level. The mitral valve level, we can see the leaflet in the mitral. In the mitral, we can see fish face leaflet, like fish face. Then this aortic valve level, we can see aortic valve level, like as Mercedes-Benz. Okay, we can see right coronary, pulmonary valve, main pulmonary artery, left pulmonary. We can see also intra-arterial septal posterior tricuspid leaflet. This picture also we can see in the short axis view. We can see papillary level of papillary of muscles is here. Left ventricle, right ventricle. Can be assessment of the in the short, can assessment for the right ventricle. We can assessment the size and functional. Left ventricle size also and functional. Aortic, we can show the assessment for aortic size. Aortic valve, we can see motion and opening, or if have the calcification or no. This is the papillary muscles. The papillary muscles show the respected of left ventricle segment are identified usually, describing if have the abnormal left ventricle wall motion. This view of the papillary muscles we can see here and assessment. Okay, this view apical view. The apical view can see 4 chamber of the heart, a transducer position on the apex of the heart, marker the direction point toward left shoulder. This is the view of the apical. We can see an assessment of the apex of the heart and assessment till we can see the pericardia space and assessment for that. Assessment left ventricle, right atrium, septum. Assessment for the septum of the heart, intra-atrium septal, left atrium, or mitral valve annulus. This picture also we can see apical 5 chamber with the aortic descending. This also assessment for pericardium. We can see here left ventricle, then assessment for functional motion of the left ventricle, right ventricle, left atrium, right atrium, tricuspid valve, mitral valve, aortic valve. Okay, apical 2 chamber view, transducer position, apex of the heart, but the marker direction point toward left side of the neck. 450 anti-clockwise from the apical 4th chamber view. It is the best assessment for what? For left ventricle, interior wall and inferior wall, and the left atrium. This picture we can see the 2 chamber. We can see in systolic and diastolic for left ventricle, left atrium, or right ventricle and right atrium. Then we can assessment of left ventricle, like same parasternum, left ventricle, right ventricle, right atrium. Okay, this apical in the 4 and apical 4-5 view. Okay, we can assessment in the apical, intra-atrial septal, pericardial effusion, and descending abdominal aorta. Subcostal 4th chamber view, transducer position under the xiphoid sternum, marker position point toward left shoulder, the subject line supine, with head slightly low, with the feet on the bed, the knee are slightly elevated. Better imaging ovocyte with abdominal relax. We should abdominal relax and during inspiration. Okay, this position, subcostal. We can see here in also wall of the right ventricle, see intraventricular septal, wall right ventricle, then wall of left ventricle, left and right ventricle, and left and right atrium. This can be assessment for the in vivo vena cava and the right atrium. Then here assessment for good for the right ventricle. Suprasternal transducer position, suprasternal from the suprasternal notch, marker direction point toward left jaw, the subject line supine with the neck hyper extended, the head rotated slightly toward the left, the position of the arm or legs, and the phase respiration have no bearing on the echo window arch. We can see here on this picture. Here we can see descending of aorta, inhumation vein, brachiocephalic artery. And this picture also we can see this suprasternal notch view. Here the aortic arch, left common carotid artery, left subclavian artery, ascending aorta, left atrium, and assessment for all that. Right pulmonary artery, descending thoracic aorta. Okay. Now we're talking about what is the classification motion abnormality. Okay, regional wall motion abnormality mean motion of the region the heart muscles is abnormal, and they have some term commonly used in the echo. Echo is the ultrasound imaging of the heart. Very often echo report use short form of the region wall motion abnormality of the full form regional different type of the region of the heart. This is the classification abnormality. In the left ventricle, the number one is the normal, then hypokinesia. What is the hypokinesia? The hypokinesia reduce contraction of the region of the heart muscles. Then akinesia. Akinesia is regional of the heart muscle is not contraction at all. When diastolic, systolic, not contraction. Hypokinesia, regional of the heart muscles is contraction more aggressive than normal. Dyskinesia, what does mean dyskinesia? The heart muscle is breaks out when the rest of the heart muscle is contraction. And you read like this, acornia. Akinesia, absent wall thickening and motion. Regional wall motion abnormality usually occur in the regional heart muscles supplied by disease blood vessels. Okay, then this picture we showing left ventricle wall motion abnormality in the apex of apex in the systole. Well, apical two-chamber view, left upper panel for the chamber, four chamber in the right, and the three chamber in the left down. In the color of blue and pink color, this meaning reduce myocardial contraction with the region myocardial infarction is clearly visible in the here. Okay. Now we're talking about what is the transesophageal echogram. It is the sinograph guide a small transducer on the tip endoscope passed into the esophageal and stomach, allow for what? For visualization of the heart by using long and flexible tube. This is the procedure. It is the invasive. This is minimally invasive producer. Cause mild, temporarily discomfortable, but it has low risk, serious the problem. Also use it to access to cardiac disorder when the transthoracic study technique difficult, as inpatient obesity or COPD, with the patient COPD. This is the better detail of the small abnormal structure. Can also produce image of ascending aorta, which arise behind the third costal cartilage of the structure, less than 3 millimeter, For example, it had thrombi or vegetation and the prosthetic valve. Okay, this is the transesophageal how to technique, the budget of the transducer from the mouth through the esophageal, then we can see the heart behind the esophageal. Okay, how does patient prepare for the transesophageal echogram? Patient does not eat or drink anything for 6 hours before the test. Discuss with your patient what is the medication patient should be take. If the patient if patient is taking medication, should be know what is the medication. Then his or her blood. If taking the warfarin, Coumadin, Plavix, or aspirin should be checked with the doctor and stop this medication before this test. Okay, the medication can be taken with the small amount of the water. Okay, what is the contraindication of a transesophageal echogram? It had esophageal pathology or cervical spine disorders. Esophageal pathology like what? Severe dysphagia, esophageal stricture, esophageal diverticula, bleeding esophageal pheresis, esophageal cancer. Okay, what is the disorder of cervical spine? Severe anteankle joint disorder, orthopedic conduction that prevent neck flexion. Okay, here we can see the transesophageal views. First, mid-esophageal views. Second, transgastric views. High esophageal views. Okay, here we can see the mid-esophageal view, location for where when the budget of transesophageal in location in the mid-esophageal, we can see structure of left ventricle, right ventricle, aortic valve. We can assessment for the pericardium, left atrium, and an interruption, left ventricle functional. We can see mitral or aortic lesion, pericardium effusion. And this picture also, we can explain what I say. Here we can assessment left ventricle, mitral valve, left atrium, left ventricle. Also this picture. This picture can be see how to functional of valve and the contraction of the heart. Okay, transgastric view for the aortic valve level, mid ventricle, and apex of the heart. Transgastric in the short axis, location for the mid stomach, we can see the right ventricle, left ventricle. We can assessment for also functional left ventricle, pericardium effusion. And this picture also we can see superior vena cava, aortic. We can see turbulent in the flow. High esophageal view in the transesophageal view. Okay, we can see here. We can see aortic pulmonary window here. We can see blood flow inside of the heart with the Doppler. Okay, what is the stress echocardiogram? The echocardiogram stress test is the test combined with ultrasound study of the heart with the stress test. The transducer sends ultrasound wave that bonus off various of part of the heart. These echo are converted into moving imaging of the heart. The imaging is displayed on the screen and required in videotape. The stress echo look at how the heart function when it is made to work harder, identical to the stress exercise test, but the echo is performed before and after exercising. Normally, all the area of the heart muscle pumping more strongly during the exercise, not with the normal in the normal life. If the area of the heart muscle does not pump as it should with exercise, this often indicated that not receiving enough blood because blocking or narrowing of the any artery in the heart. And the stress echo show area of the heart muscles. Here we can focusly heart muscle, okay, that do not receive an adequate blood supply. However, it does not provide image of actually coronary arteries. Okay, this we see type of the exercise echo. Okay. What does the test show? The echocardiogram stress test is performed to evaluation of function of the heart, mainly in the left ventricle. When the pumping chamber, when the heart is under the stress. Okay. The stress echocardiograph can be done by using either exercise, treadmill or bicycle, like this. This is the treadmill and bicycle. Pharmacological agent, dopamine, or as the stress mechanism. Exercise two-dimensional imaging is used primarily to detect the presence and extent of coronary artery disease and detect regional ischemia resulting in a wall motion abnormality. What is the indication for stress echo? Evaluation of dyspnea, or evaluation patient with known or suspected coronary artery disease, evaluation of aortic stenosis, evaluation left ventricle outflow tract or mitral regurgitation, pulmonary hypertension in the patient with the hypertrophic cardiomyopathy, evaluation mitral valve disease like mitral stenosis, mitral regurgitation, evaluation aortic stenosis, and helpful in the patient with the low gradient aortic stenosis or asymptomatic aortic stenosis, assessment of myocardial valvability, evaluation for any disease in the heart, like evaluation pulmonary hypertension as pulmonary artery systolic pressure can be estimated to at risk with the exercise. Contraindication in the stress, acute myocardial infarction, unstable angina, active endocarditis, acute myocarditis or pericarditis, aortic dissection, physical disability that prevents safe and adequate testing, uncontrolled arrhythmia with hemodynamic compromise, decompensated heart failure, acute aortic dissection, or symptomatic severe valvular stenosis. Okay, what is the stress technique? It is the protocol, the practice guideline from the American Associated of Echocardiograph, recommended symptom limited exercise according to understand protocol using either treadmill or bicycle. this guideline not that if evaluation of all motion of mean progress test, the intermediate exercise is usually used, whereas if the stress Doppler information is desired, a bicycle exercise should be considered because is enable Doppler as a wall motion evaluation during each stage of exercise. As with any exercise stress test, exercise should be performed until the patient feel that cannot exercise further due to the fatigue or symptoms. In the some, there may appropriated endpoint determined by a provided or protocol. That's it. Thank you for attention. Any questions?
أي أسئلة دكتور نور؟ I see Dr. Farid joined us today. Welcome, Dr. Farid. Any feedback or points regarding the presentation of ECHO?
شكرا وليد شكرا نور. I think
Thank you, Dr.
this is reflect the very basic knowledge that each one of you should be aware of in recognizing echo study for your patients. But it's very important to do an echo rotation. And in that echo rotation, you should learn all these principles, as well as the application of different modalities of the echo. Understanding its interaction with other imaging modalities as well, in relation to the care, the diagnosis, and the care of your patients. I'm not sure, Walid, if you can suggest a name of an educator, echo educator that can. I'm sure each center that will have an echo service. It's mandated by the Saudi Council, but at the same time, there are people who are very much into teaching these details, and they can give you one, two, few sessions in that, which would be much more practical than just half an hour review on the terms and the different images, different angles that you look at the heart with echo. So I would advise each one of you to find a mentor, review the echoes and different echoes with this mentor, and then practice reading it throughout the years over the next 5-6 years in your residency. Make sure that you review the echo yourself with the consultant or with the senior either resident or hospitalist, or even the consultant if they're available to review those issues. It's a very important modality for your care of your patients. Thank you, Walid, and thank you, Noor.
Doctor.
يعطيك العافية دكتور فريد. Any question to Dr. Noor or regarding the presentation? Anyone has any suggestion regarding any resources to use? I think Abjad previously sent a link that was very nice of images and explanation for the echo views.
Thank you, Doctor.
And he sent it to the group. You can review it. I reviewed it myself, and it was very nice, thorough. Anyway, we will not have questions now for this presentation. We'll have all because basically today is about imaging. We'll do CT, MRI. Originally, we had the plan of also doing angiogram, but we'll postpone that later. So today we'll do CT, MRI, and echo, and all of those will be examined later in a PowerPoint presentation, either by me or by Dr. Rabi Al-Ghamdi. So I'll send you the survey. The feedback survey. You can do it. Meanwhile, we'll just give you 5 minutes break for the next presentation. دكتور سلمان you wanna prepare your slides إن شاء الله راح نبدأ على الساعة 2.
طيب
هلا مرحبا يلا بالتوفيق إن شاء الله. يلا دكتور سلمان تفضل.
السلام عليكم. الصوت واضح؟ واضح. السلام عليكم. مساء الخير. I would like to thank our organizing committee and scientific committee for allowing us to present our topics. Today I'm going to talking about principles and indication of CT and MRI in cardiac surgery. طيب, imaging is a cornerstone of modern cardiac surgery, offering detailed insight to anatomical structures and disease processes. Accurate images is essential for diagnosis, pre-operative planning, and assessing post-surgical outcomes. Both CT and MRI provide high-resolution, non-invasive images options that help tailor surgical approach to each patient's unique anatomy and condition. Each modality have a strength. CT excellent in vascular and structural detail. MRI provided superior in soft tissue, contrast, and functional assessment. Principles in CT of cardiac images. CT technologies uses X-ray to create detailed cross-sectional images, utilizing rotating X-ray tubes to capture multiple angle, which reconstructed by computer into 3D images. X-ray pass through the body, varying absorption rate depending on tissue density, creating contrast in the image. Image reconstruction with advanced algorithm compile the data, high-resolution image, allowing detailed anatomical visualization. Advantage of CT, it's ideal for visualizing blood vessels, bones, and dense structure, can capture full cardiac image within few seconds, especially viable in emergency situation. And 3D reconstruction enables surgeon to visualize and rotate image, vascular structure, complex anatomy for preoperative planning. Here the CT, and here we can see how it can rotate 360 and the beam. CT techniques, cardiac gating, and contrast use. We have prospective gating and retrospective gating. Prospective gating is synchronized image capture that specific point in the cardiac cycle, typically in mid-diastole. When motion is minimal, this means it's not continuously active throughout the entire cardiac cycle. This intermittent activation results in significant reduce in radiation exposure, and the retrospective gating is continuous image throughout the cardiac cycle, allowing for dynamic assessment of the heart structure, high radiation, but provide sign image of the heart. Here in the, we can say about the cardiac gating. Prospective gating shows single image, time to mid-diastole, and retrospective gating shows continuous image capture across the cardiac cycle. Uses of contrast agent. Enhance visibility of blood vessels and coronary anatomy, highlighting stenosis, calcification, and aneurysm. Iodinated contrast agent are most commonly used in cardiac CT. And we have to figure out the risk and consideration. There is a potential contrast-induced nephropathy, need for careful assessment for patient allergy to iodine-based contrast agent. Coronary CT angiography, CTA, or in some books it's CCTA, provide a non-invasive alternative to traditional coronary angiogram, assessing coronary artery disease, especially in patients who are at high risk or unstable for invasive procedure. Technical aspect, it's captured detailed images of coronary vessel, enabling detecting of stenosis, plaque burden, and vessel patency. Iodinated contrast administered to improve. Hello? Hello? Iodinated contrast is administered to improve the visualization of coronary artery against surrounding tissue. 3D reconstruction allows for interactive viewing of coronary anatomy, assessing in surgical planning for coronary artery bypass grafting. Here is the pictures of 3D remodeling. Gated CT for heart time during peak contrast enhancement. In coronary artery, nitroglycerin given to dilate the coronary artery, beta blockers commonly used to lower heart rate. Image is usually obtained during diastole, but if information on function or valve also need, can obtain data through the cardiac cycle, multi-phase dataset. Clinical benefit, help in identify atherosclerotic lesion, calcification before become clinically symptomatic, provide mapping for coronary anatomy, which is critical for planning before CABG, useful for selecting patients who might benefit from medical therapy versus who need revascularization. In this picture, we can see from the left side the left main, and in the middle we can see the bifurcation to LAD and the circumflex. On the right side, we can see the right main, the right coronary artery. We have some limitation and consideration in CT, radiation exposure, contrast-related risks, and artifact and imaging quality. Radiation. CT involves ionized radiation, which is particle concern in younger patients and thus requiring repeated images. Strategies to minimize radiation include using low-dose protocols and prospective gating, particularly in non-emergent cases. Iodinated contrast agent can be nephrotoxic, especially in patients with existing kidney disease. Iodinized-based contrast can use allergic reaction from mild itching or rash to severe anaphylaxis. Pre-screening for renal function and allergies is essential for pre-medication protocol consideration for at-risk patients. Artifact, high or irregular heart rate can lead to motion artifacts, which can reduce image clarity. Usually the heart rate from above 65 to 70 beats per minute depends on the scanner, can provide the artifact. Extensive calcification in coronary artery can obscure the visualization of luminal stenosis, impacting diagnostic accuracy. Beta blocker are often used to reduce heart rate, and careful selection for patient is essential. Patient with arrhythmia, heavy calcification, or high BMI may be better to search for alternative study. Okay, we have some studies for cardiac CT, but not indication, but not in coronary, as pulmonary vein anatomy and stenosis, left atrial abnormality as thrombosis, period to TAVR, valvular heart disease, especially in mechanical valve, not well seen in echo, cardiac masses, precardial disease, congenital heart disease, especially shunt, ASD, VSD, anomalous origin of coronary arteries. Indication of CT in cardiac surgery, coronary artery disease, non-invasive, evaluation of coronary artery in patients with suspected coronary artery disease, detects and quantifies the severity of stenosis, helping identify candidates for revascularization, visual plaque morphology, calcified or non-calcified, to assess the atherosclerotic burden, especially useful in patients who have contraindication to invasive coronary angiography, such as high-risk bleeding, those patients who have patient who is on warfarin or DUAC, patients are complaining of renal impairment or liver disease, hemophilia, patient with GI bleeding or intracranial hemorrhage. أكمل؟ الصوت واضح؟
ايه واضح دكتور.
طيب. And here's some pictures of the coronary arteries appearing in CT scan. From the right coronary, LAD, left circumflex. Actually, there's some information the CT, coronary artery CT can provide it. Stenosis severity, plaque amount, high risk plaque features, valvular disease, CT functional flows reserve, and other information. And there is also non-cardiac findings as lung nodules within the field of view. Stenosis severity is most likely like the normal coronary angiogram, the invasive. There is the percentage and there is stages. Stage 5, the stenosis percentage means 100%. Total coronary occlusion. Stage 4, it's divided to 4A, 4B. 4B, when the left main more than 50%, or 3 vessel disease more than 70%. That means severe stenosis. 4A, more than 70 up to 99, also severe stenosis. Stage 3, from 50 to 70, or less than 70. Plaque amount, it shows us the presence, amount, and type of coronary plaque over all each vessel. In some study, burden of plaque more prognostic than degree of stenosis. High-risk plaque feature, low attenuation plaque, spotty calcium, or napkin ring sign. These features, especially multiple ones, are associated with higher future atherosclerotic cardiovascular disease risk, and also lesion-specific ischemia. CT-FFR estimate lesion-specific ischemia, useful for uncertain functional significance, from 40 to 70% lesion. CT-FFR more than 0.8 suggestive to defer revascularization. Preoperative planning for CABG, detailed visualization of artery pathway, assist surgeon to planning for graft location and path. CT can also use post-CABG to assess the graft patency in patients with symptoms, ensuring graft remain unobstructed over time. Allows for visualized surgical strategy based on anatomical insight, potentially reducing intraoperative risk and improving outcomes. Aortic pathologies. CT provide rapid, high-resolution image essential for diagnostic aortic dissection. Accurately delineate and extend for the dissection, identify the intertier, and assessing involvement of major branches. CT is a preferred image modality for assessing the aneurysmal size, shape, and location. Useful in preoperative planning to determine surgical endovascular intervention. CT is used to monitor for complications such as endoleak and graft patency after aortic repair procedure. Here we can see the axial, sagittal, and coronal pictures showing us the aortic. Congenital heart disease. CT is essential in complex congenital heart disease where 3D anatomical visualization needed. Provide clear view of structural abnormalities, abnormal vessel, septal defect, assist surgeon in planning the approach corrective surgery by providing accurate septal spatial relationship of congenital abnormalities. Particularly useful in pediatric patient or adult with congenital heart disease for whom repeated invasive procedure are risky. Okay. Here the two pictures showing us the ASD. Principle of MRI in cardiac imaging. MRI uses powerful magnetic field and radio frequency pulses to generate detailed image without ionizing radiation. Unlike CT, MRI can capture soft tissue contrast exceptionally well, providing detailed visualization of myocardium, valves, and other structure. When placed in magnetic field, protons in the body tissue align to the magnetic field. Short pulses of radio frequency energy disrupt proton alignment. When the radio frequency pulses stop, proton realign, releasing energy which detected and transforming into image. Sophisticated algorithm processes these signals to produce highly detailed cross-sectional image, especially for soft tissue. It's an ideal for differentiating myocardial tissue, detecting scarring, and assessing tissue composition. Can capture dynamic functional data such as wall motion and blood flow, crucial for assessing heart function and viability. Safer for patients requiring multiple scans or for younger patients where minimized radiation is priority. We are now talking about scene imaging and perfusion study. Scene imaging allows real-time visualization of cardiac motion and function. Acquires a series of rapid imaging throughout the cardiac cycle, creating a scene or move-like sequence. Assessing the movement and contractility of each segment of the heart, helping to identify ischemia, myocardial dysfunction, accurately measure left and right ventricles volume, providing essential data on cardiac output and function. Perfusion study, evaluation of myocardial blood flow and identify areas of ischemia. Contrast enhanced MRI performed during pharmacologic stress to observe blood flow differences between rest and stress state. Areas with reduced perfusion appears as a hypointense region, indicating potential ischemia, helps identify myocardial region with impaired blood supply, essential for patients with suspected coronary artery disease. Perfusion imaging provide critical information for determine which area of myocardium may benefit from revascularization. Late gadolinium enhancement. LGE is used to differentiate healthy myocardium from scar tissue, assess myocardial viability, help visualize area of myocardial fibrosis, scarring, and inflammation, which are critical in managing ischemic and non-ischemic cardiomyopathy. Gadolinium is administered and images are acquired several minutes later. Healthy myocardium washes out gadolinium quickly, appearing dark in LGE image or named null signal. Areas of myocardial injury or fibrotic tissue retain gadolinium longer, appearing bright in LGE or called increased signal. Delay image, typically 10 to 15 minutes post-injection, is crucial to differentiate tissue characteristics. Clinical application. Distinguish infracted from viable myocardium, aiding in decision about revascularization. Detects fibrosis in conditions like hypertrophic cardiomyopathy, myocarditis, and dilated cardiomyopathy. Fibrosis detection on LGE can help predict arrhythmia risk, supporting decision around implantable cardioverter defibrillator. Limitation, contraindications and safety concern, long scan time, artifact and heart rate dependency. Patient with certain types of ferromagnetic device as metallic implant, example, or pacemaker or defibrillator, may be unable to undergo MRI. The enhanced closed space MRI scan can challenging for patients who claustrophobia. Although gadolinium is generally safe, but patients with severe renal impairment, GFR less than 30, are at risk of nephrogenic systemic fibrosis. Longer scan time, MRI scan takes 30 to 60 minutes, much longer than CT, which can be difficult for patients to tolerate, especially those who are acutely ill. Prolonged scan time can also increase the chance of motion artifacts from patient movement or breathing. Movement during scan can reduce image clarity, especially if the patient cannot hold still for the duration. Irregular heart rhythm, such as AFib, can impact synchronize and reduce the quality of function or perfusion image. Indication of MRI in cardiac surgery, myocardial viability. MRI, especially with LGE, help distinguish between viable myocardium from non-viable scar tissue. Critical for planning revascularization, as region of viable myocardium benefit most from revascularization procedure. Identify viable myocardium can prevent unnecessary intervention in scar non-viable. There's no benefit from revascularization. And here we can see the viable is darker than non-viable. MRI is the gold standard for accurate measuring ventricular volume, ejection fraction, and wall thickness. So it aids us to diagnose hypertrophic cardiomyopathy, dilated cardiomyopathy, and restrictive cardiomyopathy. And either detection of myocardial fibrosis, as in hypertrophic cardiomyopathy, available to assessing arrhythmic risk and determine stability of ICD placement in selected patients. Valve disease. MRI provide high-resolution image with valve leaflets and surrounding structure, aiding to assessing stenosis, regurgitation, severity. Quantify blood flow across valves, helping to evaluate the degree of regurgitation or stenosis, guiding to the surgical planning. Real-time image of valve motion through cardiac cycle are essential for complex valvular pathology. Here we can see the fibrous membranes around the aortic valve that obstruct the outflow from left ventricle, as in from the left side, and we are going up to the right side. Congenital heart disease. MRI provide non-invasive and comprehensive 3D view of complex congenital heart structure, useful in planning corrective surgeries, monitoring congenital repairs over the time, especially in pediatric and young adult patients. Particularly beneficial for young patients who require repeating imaging over their lifetime. In the left picture, we can see the heart in the right side of the patient. And the right picture, it showed the Epstein anomaly. Precardial disease. MRI can detect increased precardial thickness and characterize effusion, aiding to diagnosis, constrictive pericarditis, identify anomaly, inflammatory changes, fibrosis, and other tissue-specific details in precardial disease. Provide clinical insight to distinguish between constrictive pericarditis and restrictive cardiomyopathy, guiding appropriate surgical or medical treatment. In the picture here, we can see the constrictive pericarditis, the thickness on the cardiac wall. Conclusion. CT provide high-resolution image for vascular structure, essential for condition require rapid assessment, such as coronary artery disease, aortic pathologies, and preoperative surgical planning. MRI offers superior of soft tissue contrast, allowing detailed assessment for myocardial viability, cardiomyopathy, valve disease, congenital and precardial conditions. The comparison table between CT and MRI. Primary uses CT for coronary arteries, aorta, MRI for myocardium, valves, congenital. Strength, vascular detail, and speed. MRI, soft tissue contrast, and no radiation. Typical indication in coronary artery disease for the CT and aortic pathology, cardiomyopathy, and viability for MRI. Choosing the modality, each modality has unique strength and choose depend on specific clinical question, patient factor, and diagnostic requirement. Tailoring imaging decision to patient need, ensure optimal outcome and minimize risk, such as unnecessary radiation or contrasted exposure. Advances in CT and MRI continue to enhance cardiac surgical planning and patient management, making imaging as a vital part of modern cardiac care. Thank you, and here's the reference.
يعطيك العافية دكتور. أي سؤال للدكتور سلمان؟ طيب الآن إن شاء الله راح نفتح السيرفي حق السكند برزنتيشن، أو عفوا الثيرد برزنتيشن حق الدكتور سلمان. من الدكتور فريد any point questions or feedback regarding the presentation?
Again, very well done presentation covering all the aspects really that you should be aware of. Recently, last week, there was a very nice conference in Riyadh. كان the Saudi Health Council المجلس الصحي كان مترأسة مع أظن اسمها جمعية القلب، بس ماني متأكد والله، اللي هي heart surgery, cardiac surgery forum. The first few lectures were about imaging, and one of them was very intriguing that will change the concept of applying CT in our practice. They expect in the next year or two, there will be dramatic change in how we evaluate the patients. I think they have it recorded, and I think if you have access to that, please review it, or at least keep an eye on this new change. it basically talk about the why are we doing those images and to answer those particular questions. So in particular for coronary artery ischemic heart disease, for example, they talk about the integrity of the anatomy of the coronary, if there's stenosis and if there's complete blockage. And then they talk about the specifics of the stenosis itself, what structures in it. And if it has calcium, they are also talking about different kind of calcium that's involved. I was talking to a surgeon who's sitting, two surgeons who are sitting beside me, Dr. Abdulaziz Al-Baradi and Dr. Ahmed Jamjoom, and the information was intriguing, how this new knowledge is coming up. So they talk about, excuse me, they talk about, for example, soft kind of calcium versus hard kind of calcium. One of the surgeons, I think Dr. Ahmed Jamjoom, said that if it's hard, it's easier to do endarterectomy, for example. If it's soft, it's maybe better to deal with it otherwise. They talk about the flow, measuring the flow or equivalent to the flow that we use in FFR. And that can, with these decisions, the CT scan can tell you which vessels to tackle, which vessels are useless to tackle, which vessels will benefit the patients, and what are the expected results for that. And if the expected results is not as good, it will reflect on the technical aspects. So anyway, please keep an eye on the recent advances on the CT scan in particular. It's intriguing, and I think it will change, according to the presenter, it will change our practice in the next year or two. Thank you. Thank you, Walid.
شكرا دكتور. Very interesting development. And I think Amjad also shared, يعطيه العافية, Amjad is sharing all the educational material with our group. He shared the link for that conference. Anyway, now Dr. Rami, I think he's busy in the OR, so I'll be presenting the questions instead. Okay. Is it clear now? Is it clear and large?
Yes.
Like, okay, so the first case, I have 5 cases here. 2 of them are angio, so we will be skipping it for today. 2 cases of echo and 1 case of CT. The first case is the echo case. All echo cases, we're going to be discussing just a few points regarding some identification of structures, ejection fraction, and whatnot. So the first case, this is a 60 years old male, referred as a case of non-STEMI. He's diabetic hypertensive. Other labs, his labs are within normal range. 1 second. Let's put it here. So this is his echo. Who can help me with reading the echo? I'll just ask very simple questions to begin with. Like, what is this? What are the views that we will be watching or seeing? Anyone? Dr. Ashok, are you here? Dr. Noor Al-Jasser? Dr. Amjad? دكتور نور أبو قمي موجودة معنا؟ طيب مين قدم عليكم؟ دكتورة نور. دكتورة نور, would you be kind enough to tell us the views that we are watching in this echo?
I think
So we'll play it one by one. Some people are replying in the chat. My mic is not working. Okay, no problem, دكتورة نور. طيب دكتورة نور,
yeah.
so this is the first view. 1 second. Yeah,
Yeah.
this is the first view. What do you think this view is? It's clear, yeah?
Yeah, it's clear. Bar stern short.
معلش,
axis.
1 second. I think, let me try to fix it for you. طيب, yeah, this way is easier, no? Yeah, أفضل. طيب, هذه قلتي short axis? This one.
Yeah,
Short axis or long axis?
this.
Yeah.
This is the short.
مم. طيب ايش رايك في هذه؟ خليني اوريك ثاني. هذه ايش رايك؟ طيب, you're right, this is the parasternal axis
Yeah.
view, but this is the long parasternal.
This is the long. Yeah,
Yeah, this is the long, and this one is the short.
short. Yeah.
And maybe you can like memorize it as when you see the LV in a circular fashion, this is the short, you're cutting it short. And if you're actually, the naming is probably due to the, يعني, if you see the plane, you'll understand it more, the way that they're cutting the heart. Anyway, Dr. Salman. دكتور سلمان موجود؟
دكتور وليد, I can
دكتور حسام.
also participate if you don't
تفضل.
mind.
ممتاز.
Okay.
طيب دكتور, in the long parasternal, can you identify the valves that we usually see?
Yes, okay, so this is the parasternal long axis. The most, let's say, inferior is the posterior mitral valve leaflet, and it's here the papillary muscle, and the one in front is the anterior mitral valve leaflet. And yeah, on top, and next to it is the aortic valve.
This one? Or this one?
This is the LVOT والaortic.
أحسنت.
طيب. above موجود aortic valve. And will enter ventricular septum and the right ventricle.
ممتاز, أحسنتي.
From bottom to top.
ممتاز. طيب, now we're putting color on the mitral valve. I want you to tell me if you, يعني, if you think there is any abnormality, either stenosis or regurgitation.
Okay. Yeah. I don't know if I,
طيب, and I know you're slightly confused because of this color that is coming on top, but if we'll focus only on the mitral valve.
Mitral valve, okay.
Yeah.
Okay, I don't see any jet.
Okay, excellent. So, يعني, when I'm asking you all of these questions, initially start, and this is advice, يعني, for all of you, don't criticize yourself on just broadly understanding the echo. The echo is difficult. They have a fellowship for this. And you're not gonna become cardiologist all of a sudden. You're a cardiac surgeon now, and you're only a resident. It will take you a very long time to get all of this. So from the start, even for ejection fraction, all the valve abnormality, initially, at least you just want to see, is this looking normal or not normal? I don't care if you identify that this is mild, moderate, or severe mitral stenosis, for example. And slowly, but surely, eventually, with the years, you'll be able to identify the degree. You'll be able to identify whether the stenosis is severe, it's more not severe, whether the jet in regurgitation is eccentric, whatever, all of these details. But for now, your answer is more than satisfactory as an R2. You said it looks, for me, it looks normal. But I'll show you the aortic valve. So, no, not the aortic valve. Yeah. So what is this view?
Okay, this is the short axis parasternal view at the level of the aortic valve.
Mumtaz, excellent. What is this valve that we're seeing?
In the middle, the aortic valve.
Excellent. Type. We're putting color at the aortic valve.
Okay.
Actually, before the color, on visually, does the leaflet look thick? Do they look calcified? And does it look like the patient might have aortic stenosis?
Let's say I cannot see all of the leaflets, but
they don't look thick.
They don't look thick. Yeah.
خلاص. Okay, so you have first impression that initially I see the valve leaflets, they don't look very thickened to me. And maybe it is normal, maybe it's not. We'll see. Put color on it. We'll see it in other views. We saw it in the parasternal, it didn't look thick in particular. We saw it in the short axis. It looks fine, صح? So initial impression, it looks normal. We're putting color on it now.
Okay.
Do you see? What do you think? It would be much easier if we had maybe, actually we do have it. So yeah, what I usually do to follow, I usually do two things. I will slow it down and go frame by frame. Tamam? Why am I going frame by frame? Just to follow the movement with the ECG.
With the ECG.
Yeah, because this will tell me that this is systolic diastole.
Because I only saw two colors, but أحس إن I don't. Okay, systolic.
Okay, we lost the view. Anyway, it usually in barograms when you're viewing it looks easy. طيب. So what is this view?
Okay, this is at the level also short axis, short axis parasternal, and I think this is at the level of papillary muscles.
What about this?
This is the apical view, four-chamber.
Fantastic. طيب, if I would ask you about the ejection fraction of this patient, what do you think? And your answer, I don't want a number. I just want it. Does it look normal? Does it look maybe moderately reduced, or is it severely reduced? Because you're not cardiologist, صح? I don't want you to say, والله 40 to 45.
I think I don't know, but I don't know. But I think
keep watching the views. You cannot judge on only one view, صح? Okay. So keep watching the view and tell me. You know. Wait, this is not a good view to judge.
Four-chamber.
Okay.
I think it's maybe let's say mild to moderate.
Mild to moderate.
Yeah,
okay.
I think.
Okay, excellent. طيب, you're almost correct. It's mildly reduced. So 40 to 40. Sorry, it was 45 to 50.
No.
طيب, how did you come up to this conclusion? Is there any criteria that you're following?
Muscle contraction, also
okay,
dilatation of the ventricles, in general.
Okay.
how much the left ventricle is dilated, and also يعني mainly muscle contraction from the
You're right. So the first thing that you would be looking at it usually is the contraction of the muscle. And you can see this usually clearly in the long parasternal or the short parasternal. Usually those are the two best view, and the fourth chamber, of course. The second thing you said, the muscle, the LV dilatation. I think you're probably referring to what they usually call excursion. So the movement of the walls to each other. And you assess the volume of the LV in diastole versus systole. So if you see the muscle moving toward each other, in a good fashion, you need to look at multiple echo to understand what does it mean normal, moderate, or severely reduced. But they usually cardiologists usually either qualitatively assess this visually, or they can do it quantitatively with something called shortening fraction. Shortening fraction, you put a line in the middle of the LV, and then you measure the 2 points at the point, يعني from the mid, you put a line and you put a point here and point here, and then you measure the change in this between systole and diastole, and it will give you a fraction. Usually, I remember if it was less than 25, that's abnormal. So you can almost يعني visually estimate this. والله, do I see shortening in the LV يعني of less than 25% of the LV volume? Okay, this is abnormal. والله, this يعني looks like, you know, they are coming together. I can see the muscles also thickening. يعني this looks normal. Another thing that you can look at is the movement of the anterior mitral valve leaflet. This is something called E-point septal separation. There is quantitatively, they can give you a number. Zero. There are numbers. They give it to you, and if it's below certain, if it's more than 1.7, so if the distance between the mitral valve leaflet in early diastole to the septum is more than 1.7, this is abnormal. You can يعني visually assess this, whether the mitral valve leaflet in early diastole, does it touch the septum or no? Usually you want it to be very close, 0.7. So here we can see it is almost touching. So يعني on visual assessment, it looks normal. So these are the things that you'll be looking at. And when I first saw it, I thought it was normal, but however, in the the database that I took it from, it said it's mildly reduced. So your assessment was more accurate. Well done.
Thank you, Dr.
Dr. Farid, any feedback regarding Tessama answers on this case?
No, thank you. I think it's healthy discussion and to the point. Thank you.
طيب, we'll skip the angio. We'll leave this for now. Let's go to the CT. طيب, دكتور سلمان, انت كنت تقدم السي تي, yeah? دكتور سلمان؟ دكتور عمر؟ دكتورة ذكرى, ممكن تساعدينا في قراية السي تي؟ دكتور سيف؟ موجود دكتور سيف؟ It's very simple CT. دكتور حسين؟
ايوه دكتور راضي.
ممكن بالله تقرأ لنا السي تي؟ أباك, there is a very يعني clear diagnosis here from the CT. I want you to see it. So احنا as a cardiac surgeons, we're looking usually for heart and great vessels, صح? So focus on those. طيب that's enough. The rest is for vascular surgeons. طيب دكتور, what did you think? Did you pick up the diagnosis?
Yeah, if you actually want me to give just a spot diagnosis, I think there is type A dissection.
Excellent.
I can see intimal flap in the ascending aorta.
طيب. Now, after the spot diagnosis, since you picked that up, we'll ask you some other questions. I want you to see, where did it start? Where do you think it started? So I want you, basically what I'm asking for is the extension of the dissection flap. Where does it start and where does it end? Huh? So I'll show you these images. So my question is, do you think that the aortic root is involved?
Yeah, I think that.
You think it's involved? Do you think the dissection is extended to the coronaries? Do you see the coronaries or no?
Actually, I'm not sure. I can say it here.
طيب, what about this thing, the structure that is going here?
Yeah, can you move it again? Yeah, I can now see the coronary, but I cannot see actually.
You cannot see this actually. So
yeah, if there is extension to the coronary, I'm not sure.
Okay, so أنت عرفته صح؟
أيوه.
More than excellent. If you tell me that والله it doesn't look like, and you're not a radiologist. If you tell me والله it doesn't look like there is any dissection flap, this is more than sufficient. طيب, do you see the other coronaries ولا هذا ايش, left ولا right?
This, the one you are pointing to?
اي هذا.
Yeah, this is the left.
ممتاز. أحسنت. طيب, what about let me show you. This one. This is the right.
Which
هنا.
where are you pointing, Victor?
هذا.
Here. Yeah.
هذا right صح؟
Yeah.
Hey, does it look like involved?
Sorry?
Does it look like it's involved?
Yeah, maybe here in the right I can't see maybe difference in the contrast density. So maybe there is, maybe there is some involvement.
طيب. Usually the aortic root is we're talking about something that is below the coronaries or above it?
The aortic root, if there is involvement with the aortic root, there may be a possibility to involve the coronaries, but I don't think it's necessary to involve.
Okay. But do you know where does it start from and where does it end? The root?
Yeah, actually, it's the part of the aorta starting from. Actually, it's a part of the LVOT, involving the sinuses of the aorta.
You mean okay, till the sinotuberal junction, صح?
Yeah, sinotuberal junction.
طيب, here it's not clear whether the root is involved, to be honest, or not. ممتاز. طيب, let's move to the other end. Where does it end? And do you think the arch vessels are involved ولا لا?
I think it ends before involving any arch vessels.
ممتاز. أحسنت.
I can't see anything.
Can you identify the arch vessels? Just for
Yeah.
طيب. What is this?
Which one?
هذا.
This is the innominate artery.
ممتاز.
Left common carotid, left subclavian.
أحسنت. خلاص, well done دكتور. More than excellent. دكتور فريد, feedback discussion.
Yes, and just like you said, as you progress in your residency, you try to look at these images at different planes And even sometimes a radiologist can help you with special access to look at specific area of the aorta, for example, at a certain direction. So you can define exactly the orifice of the, let's say, in this case, the right coronary or the left coronary, and if it's involved or not involved with that particular dissection. But the general principles, of course, this is a contrast study, so you'd be able to look at the venous structures as well as the arterial structures and the valvular part. And if it's dynamic, it can show you even some of the regurgitation and quantify that as well. So just like I said earlier, CT scan has been really progressing very fast in the last few years, and you'll be seeing something amazing with the next generation. By the way, the presenter said that you can get those images that he posted in the conference with any good quality CT scan that most of the hospitals have at this time. All you have to do is just add the new software to that. So that's something interesting. Thank you.
شكرا دكتور.
دكتور وليد.
هلا دكتور.
Can I ask something?
تفضل.
In this case, يعني can you tell us if the coronary is involved? I want just to know.
I don't know يعني to me it doesn't look like it's involved. I don't know about the patient يعني ما هو it's not a CT يعني I brought. These all slides were prepared by Dr. Rami يعطيه العافية, but he was busy unfortunately in OR, so he couldn't present them. Maybe if he was here, we'll ask him later.
Okay, the good thing that you have raised that question. I think you should always ask yourself what other structures are involved, the extent of the dissection, and that will help you plan your the surgery, the safe surgery for this patient. Thank you.
طيب هذا شوية صعب السؤال. نسأل واحد أرفع. دكتورة سارة لابون. دكتور فيصل غامدي. دكتور هاني برنامج. دكتور أمجد. دكتورة سيرين. دكتور آيات الحسن.
Yes, hi, Walid.
هلا دكتورة.
So, is there a thinning there of the LV?
عفوا.
Thinning
We'll
wall
see them just now.
you are running them? Okay, طيب.
لسه ما we didn't run it. Yeah. So he's patient STEMI. Based on the echo, what coronary do you think that is involved? That's the question.
Yeah.
Sorry.
I think it's thin-walled LV and
no, we're asking about the coronary. So yeah.
Yeah, I mean so the finding is gonna be like maybe the anterior wall and the LV is involved, maybe the LAD then.
ممتاز. So you think it's the LAD territory, صح?
Yeah. Yeah, exactly.
You're right. So we'll see more reviews, and you can comment if there is anything specific that you're looking at. Which segment, all segments do you think moving fine, or which segments are moving not so good? For example, in this, This is the most easiest usually used to first assess for any regional wall of normality.
Yeah, I think it's the anterior. The anterior is not moving.
What about the septal?
Hypokinetic.
Mhm.
Maybe, yeah.
Type, hold on, doctor. So usually when we first start learning about the regions or the territories of the myocardium, I think it's best if you start with the short axis views. Usually they're very easy to see, and you have like a circle that will teach you that this is the anterior, this is the septal side, this is the lateral side, and this is the inferior. One of the tips that cardiologist taught me was to identify, wallahi, this wall is supplied by the LAD, this is by the RCA, or this is by the circumflex, is basically whenever you hear the word anterior, this is covered by the LAD. Septal, this is also LAD. When you hear the word inferior, this is by the RCA, and lateral is by the circumflex. So when you have, for example, like here we have, this is at the level of the papillary muscle. So at the papillary muscle, the way that they usually, or mid cavity called, the way that usually they separate it is, this is the anterior, this is the anterior septal, this is the inferior septal, this is inferior lateral, anterior lateral. So here we hear, or here rather, we hear anterior lateral. So I hear two words, anterior and lateral. I think this is usually covered by the LAD and circumflex. So as Doctora correctly identified, this is hypokinetic. Maybe because it's also supplied with circumflex, I don't know. This is good enough to know. This is inferior lateral, so RCA and circumflex. This is inferior, so this is RCA. This is inferior septal, anterior septal. Now after this, obviously you'll need to go through all levels of the short axis. Now the next step, which is slightly more difficult, but not that difficult, once you understand the planes that you're cutting the LV from, there is a picture, if you look for it on Google or in books, they will show you the short axis view, and they will cut it at different levels, and accordingly they will tell you that this is the plane. This is the plane of that you usually see in parasternal, and you'll be able to tell, okay, so what I'm seeing parasternal view, I'm cutting the LV in certain manner. I can tell that, okay, this is the basal anterior septal, based on the plane that they're cutting. Usually, let me show you. So parasternal, usually you're cutting the LV in this plane. So you'll be seeing the anterior septal, and you'll be seeing the inferior lateral. So if you go here, so this is the basal anterior septal, this is the basal inferior lateral. Here, again, anterior septal, but this will be the mid, this mid inferior lateral. In here, you'll be seeing the apical anterior and apical lateral. As I said, it's depending on the way you cut. So if you go all the way to the apical view, let me show you an apical view. So this is at the apical level. You'll cut it this way. Here, all of this is anterior, and here this is lateral. That's why you see it anterior and lateral in the parasternal at the apical level. Anyway, so basically this is the progression that you want to advance through to understand. If you try to memorize there are some diagrams that show you all these wall segments, and you'll have, if you try to memorize them, as I tried for the past 3 years, it's very difficult. I was only able to understand how cardiologists identify them by speaking to a cardiologist, by understanding the plane. Anyway, that's it for the cases. Thank you all for your attendance. Any questions or feedback regarding the questions or the other presentations, please feel free. Dr. Farid, any closing words?
Yes, please. All these images now are involved heavily with artificial intelligence, as well as some of the surgical fields. So pay attention to that. I think it will become integral part of your knowledge and management of patients. Thank you.
Thank you, Dr. Farid. Thank you all. Hope to see you next week, inshallah. Have a good weekend.